Dr. Sameer Dalwai, who is a well-known figure in the neurodevelopmental pediatrics. He is a developmental pediatrician working in Nanavati Super Speciality Hospital, and he's a founder and director of New Horizon Child Development Center, and he is a recipient of various awards, and he is the ex-president of chairperson of Neurodevelopmental Pediatrics chapter of IAP. He has given a lot of publications, and he's been author to the consensus guidelines for autism and ADHD and other guidelines. So welcome, Dr. Sameer, and over to Dr. Gaurav, who will be presenting a case, and then Dr. Sameer and we can be discussing the various aspects on the case.
Thank you, Dr.
Gaurav.
Pareen, for your kind invitation and introduction. Thank you very much.
Dr. Gaurav, you can
Yes,
start.
Yes, ma'am. Good evening, everyone. I'm Dr. Gaurav Alra, second year DNB resident in Sir Gangaram Hospital. So I'll be presenting a case of 5-year-old male child who is resident of Delhi, Hindu by religion, and the informant is mother, and she is reliable. And the child came to us to the developmental OPD. So child presented to us with the chief complaints of not able to walk without support and increased tightness of both legs since 8 months of age. So I'll be starting with the birth history of presenting illness. Baby was born to a 24-year-old mother and 28-year-old father at 38 weeks of gestation by normal vaginal delivery. And the birth order was first, and the mother conceived spontaneously after a non-consanguineous marriage. So antenatal history. In first trimester, she received supplementation. There was no history of fever, rash, drug intake, radiation exposure, alcohol or tobacco, substance abuse, and there was no history of bleeding per vagina. In second trimester, she received tetanus vaccination and supplementation. No history of headache, blurring of vision, or hypertension. No history of there was fetal movement was felt at 20 weeks of gestation, and there was no history of bleeding per vagina. And the USG scan done at second trimester was normal as per mother. In third trimester, the fetal movements were appreciated well. There was no history of headache, blurring of vision, or hypertension. There was no history of burning maturation or leaking per vaginum or bleeding per vaginum. The ultrasound scan done was found to be normal. But the reports were not available. After antenatal history, we'll go to perinatal history. There was a spontaneous onset of labor. However, labor was prolonged and the baby required forceps application. And the baby did not cry immediately after birth and was shifted to NICU at birth, and the delivery was done at a government setup. Details after the birth or the resuscitation date is not known. The birth weight of the child was 2.5 kgs. Baby remained in NICU for 5 days, where baby was kept on oxygen by nasal prong, then slowly weaned to room air. Feeding was started on day 1 by OG feeds, and the direct feed was started from day 3. Mother saw the child at day 1 of life and noticed the child was dull and was on oxygen by nasal prongs. As per parents, there was no clinical seizure reported, and the baby was discharged on day 5 on direct breastfeeds. There was no history suggestive of jaundice or any infection. So baby was apparently well, according to mother, till 6 months of life, when baby developed an episode of abnormal body movement, which was GTCS, with rolling of saliva and uprolling of eyes, which lasted for about 1 minute, and there was no post-ictal drowsiness, according to parents. Then the parents did an OPD consultation, and this child was started on Levipil syrup, on which seizures were controlled. Mother compared the growth of the child with a neighbor's child of same age and found that the baby has not attained the milestone, that till 1 year of age, the child was not able to sit, and there was increased tightness in lower limbs, and the parents noticed that there was difficulty in changing diaper, and hence OPD consultation was again sought, and the MRI brain was done at 1 year of age, according to which the doctor advised them therapy and for a regular follow-up. Parents did therapy till 3 years of age, and then they stopped going to the therapies. Now they presented that the child is not able to walk without support, and there is increased tightness in lower limbs, So hence, they visited to the child development clinic for further follow-up and treatment. So developmental history. Uh,
Can we stop here,
yes,
Gaurav?
ma'am. Yes,
We want to discuss few things.
yes,
So as you said that there was a clinical seizures. How
yes.
do the parents know there was no clinical seizure? Go back to the previous slide. As you said, the child didn't have a clinical seizures. As per parents, clinical seizures were not reported. What does that mean?
When the child was in NICU and they were not told that there was any like seizure thing, or they did not see any abnormal body movements of the child.
Hmm. So preferably in cases of history, we are supposed to use terminologies which are parents,
Normal body.
okay.
Yes,
So because this is clinical seizure, parent will not be able to appreciate the clinical seizures, that too in a small child. So if the seizures were not there, what are the other indicators you would look for a child who has suspected HIE?
ma'am, we'll have to see normal neonate behavior.
Mm,
That is, he is awake for 30 minutes, then he feeds, and again goes back to sleep for 2 to 3 hours, then again
mm,
wake up and for feeding.
mm,
And we'll also look at the activity of the child, the movement. Is he active? Or we'll also look at the cry. Is he crying? The cry is good. He's sucking vigorously for feeds. And we have to
mm.
look at all these things. And
So do you think the child had HIE at this stage?
ma'am, according to mother, she said the child was not that active. He was dull on
Mm,
day one. And
mm,
also he was not started on direct feeds on day
mm,
direct feed was started on day 3.
mm.
So there is
Yeah,
slight possibility
uh-huh.
there was a insult.
Which level? Which level?
I'm grade
Because
1 or grade 2.
grade grade one may, if the grade one is there, then what happens normally? What is the clinical presentation?
I mean, grade 1, the child is according to the conscious level, child is hyperactive.
But you
And
said he is dull.
yes, ma'am.
Hmm. So then you have to ask for the history. Very importantly, in such children, you have to ask children history of feeding difficulties and excessive irritability, isn't it?
Yes, ma'am. Yes,
So
ma'am.
did you ask for that?
Ma'am, negative history, I asked if there was.
तो तो नेगेटिव हिस्ट्री यही बताओगे बच्चे, वो नेगेटिव हिस्ट्री बाद में बताओगे, कैसे पता चलेगा? यू वंस यू आर सेइंग, यू आर
Yes, ma'am.
डिस्कसिंग हियर, सो वी एज एन एग्जामिनर वी नो दैट what level of epoxy is there. So you have to ask whether there was an excessive irritive. तो HIE है कि नहीं है, कैसे पता चलेगा?
Yes,
Isn't
ma'am.
it? So then next slide. Go to the next slide.
Yes, ma'am.
As you said, the baby was apparently well and he had GTCS. So in history, we are again telling you, don't use terminologies which are medical terminologies.
Yes, ma'am.
Secondly, you said 6 months, till 6 months he was fine and he had seizure, and he must have seen some doctor or probably pediatric neurologist or somebody who has prescribed the anticonvulsant. So was he referred for the developmental evaluation or not that
No,
time,
ma'am. At that
or
time, they were not referred. Only
they
medication was
were
started.
only medication was there? And at that time, what was the clinical condition of the child? What was the head control, and by history, what was the clinical status of the child at that time, 6 months?
At 6 months, head control was there. The child attained head
Hmm.
control according to the history at around 4 months, according to mother.
Okay,
And that
according
has
to mother, the
discussed. That
child
is
has
the
achieved head control at 4 months. He was
yes, ma'am.
fine.
Yes, ma'am.
So then he had seizure.
Then he had around 6 months of age.
Oh, so he was controlling. And then when did they started noticing that there is a problem in the development?
I'm at around 8 months. They noticed that there is increased tightness of the lower limbs.
Hmm.
While changing the diapers. Also, when I asked if the child
That
sucked.
time at 8 months, child was sitting, was able to sit.
No, ma'am. No, ma'am.
And at 6 months, when he had a seizure, was he able to sit without support?
No, ma'am. Only head control was there.
So that means he had not achieved the milestones at that time also,
Yes,
isn't it?
ma'am.
There was a delay. Okay. So
Yes,
this will give you an idea whether the child has a problem from the beginning or he has developed after the seizures. So that will help you to find out the etiology, isn't it?
yes, ma'am.
Dr. Samir, would you like to add something?
Yeah. So it was Gaurav, very well done, yeah. Well done. Because as a resident, you are doing a lot of work in neurology here now, and that was good. Just a few points just to share
Yes, sir.
is that in the mother's history, you did mention there was supplementation and all. You did mention she was 24 years, but the mother's nutrition is also very important to pre-conception or peri-conceptional nutrition, just to get you additional points with the examiners. And then again, you mentioned everything about the vaccine. You gave a very detailed history around the health of the mother for infections, blood pressure, etc. That was very nice. And then what madam has been asking you, she's been giving you the clue that what could have made you feel that the child has had a problem during birth, because your entire case later, the whole DD will be between an HIE related cerebral palsy or some neurological disorder or regression, etc. So what madam was trying to give you a clue was to convince the examiner that the problem started around perinatal itself in the first few months.
Yes,
And
sir.
hence, you mentioned that the mother saw the child on nasal prongs. So that is one thing on history. Other thing is when she breastfed the baby, did she find the suck active? Did she find the baby suckling vigorously? Did she find the child getting tired or cynos? So these things will be very important. Did she find, like madam said, the child very irritable, crying all the time, difficult to soothe, difficult to console? The other point is whether any disturbances in the sleep well cycle, sleep wake cycle. Was he getting up very quickly? So all those things can tell you in the early neonatal period whether there was any problem. Then when you went on to the other part, which again madam asked you, give you a clue, was the child's, what about the child's vision and what about the child's hearing? So you have to always look for these two very important sensory things. Was the child following the mother around in the room? Was the child able to hear? Was the child startling? Even by that time, the child tracks the mother around and even turns towards sound. And then, like madam mentioned, you notice that the child had seizures. You mentioned about the seizures, but whether they had a fever, whether the child had poor feeding a day or two before the fever, whether the child had cough cold, or vomiting, loose motions, diarrhea, or crying during micture, any illness which was the cause of the fever. Because what you are telling us, I'm sure going on that the child had HIE at birth and the convulsions were probably a consequence of that. But if it is not established that there was a big problem at birth in the history, because you didn't get that kind of history from the mother, then you are going to run into trouble. Are you trying to say that the seizures started the problem? Did the child have a head injury or something like that? So just make sure that you mentioned that there was seizures without fever, the child was not sick otherwise. Then you are saying, okay, there was no brain event at that time. The event had happened earlier. Yeah, you're doing well.
Yes. So, developmental history, gross motor, neck control was attained at 4 months, and the child started sitting without support at 2 years of age, and standing with support at 3 years of age, and now at 5 years, a child walks with support, with a developmental quotient of 20, motor 20. Fine motor, both hand approach was present at 7 months, and one hand approach was present at 12 months, and now the child is having immature pincer grasp and a developmental quotient of 15. Social and cognitive. Social smile was achieved at 3 months of age. The child recognized mother at 4 months of age, and there was stranger anxiety started at 7 months of age, and plays peekaboo at 12 months. Copies parent simple task at 2 years, and now child knows his full name and gender with a developmental quotient of 60. Language, cooing started at 4 months of age, and monosyllabic started at 6 months. Bisyllabic like dada, mama started at 9 months of age, and meaningful words like saying papa and looking a father started at 12 months of age, and 2 to 3 word sentence at 2 years of age. Now the child can repeat three numbers with a developmental quotient of 60. Vision and hearing, child looks at the sound source and follows rapidly moving objects.
So, Gaurav, we would appreciate if this is a history, this is not an examination. you have to first collaborate your history by the examination, and then only you give the development quotient, isn't it? So in the history, please do not mention development quotient. We will talk this in the after the examination.
Okay.
Here you can just say that child achieved milestones in this sequence, and at present he is doing this, so that we get an idea how was the progression and what is the current status of the child.
Yes, ma'am.
Dr. Sameer?
Yes, yes.
Yeah, that's fine.
Okay.
So you said vision. एक बारी go back. You said vision and hearing. Looks at sound source, follows. Uh, looks at sound source and follows rapidly moving object. Once you have given the language milestones so well, that child has developed 2-3 word sentences, and so looking at sound source does not mean anything, isn't it? Otherwise, you could have given in the sequence. Normally, a child at 4 months start turning his head towards the source of sound.
Yes,
But
ma'am.
here, your child is functioning almost around 3 years, 4 years.
Yes.
So you have to use the appropriate levels.
Yes.
Okay. Fine.
So there was no history of excessive irritability or behavior abnormality. There was no history of abnormal twisting or abnormal posture. There was no history of vision or hearing abnormality or sensory impairment. There was no history of frequent coughing during feeds or regurgitation of feeds. There was no history of respiratory problem or pneumonia. No history of constipation, contracture or deformity, or loss of previously attained milestones.
How do you find out that there is no sensory impairment?
Yeah.
Ma'am, if मतलब on pain and touch, pain or touch, the child reacts. So the parents said कि there was no sensory impairment there.
Like as a development pediatrician, हमारा sensory impairment सुन के ना कान खड़े हो जाते हैं. So we find it very, like, I think it's very difficult, and saying this statement is on history is difficult, I believe. Dr. Sameer, what do you say?
Yeah, yes, yes. So,
Yeah.
but Gaurav, what you must focus on when you say the word sensory at UG or PG level, you have the two most important senses are vision and hearing. So don't go into all those sensory, integration and all that. That can be later, maybe if after you do very well, you can take those questions. But never ignore the hearing and the vision part of it. Then, of course, touch and pain and etc. That can come later.
Yes.
So history में what is the significance of sensory? Normally, I think during examination, neurological examination, yes, it is an important, motor and sensory is important part. But in history, as Dr. Sameer said, vision and hearing is good enough, and rest about the motors and other thing which you have asked about, the comorbidities which you have
Yes, ma'am.
definitely asked for. Yeah.
Why are you asking for respiratory problems?
Because there is more incidence of more chance of respiratory problems in child with neurological delays and development delays.
There can be aspirations, there can be,
Aspiration.
so, and because of the difficulties, muscular difficulty, there can be neuromuscular disorders also, isn't it?
Yes,
That
ma'am.
will give you a clue that what all muscles are involved, what all areas are involved.
Yes.
What abnormal twisting and posture?
This is to ask this for any dystonia or extrapyramidal symptoms.
So,
Yeah.
what was the posture? What as you said, this child had excessive tightness of the limbs, isn't it? As you said, they
Yes,
had
ma'am.
difficulty in changing, and so the posture was normal. There was no abnormal posture. It is highly unlikely a child who has so much of tightness at 5 years of age and his posture is normal. So by saying so, you are saying that there was no abnormality in the posture.
There was
Was
a
it normal?
little extension. Their legs were in little extended extension only. And while asking for the child walks with support, and while asking in history, the parents also said that there is a history of toe walking also there because of extended posture.
So we cannot say there is no history of abnormal posture,
Yes,
isn't
sir.
it?
Yes, sir.
When you say in this line, no abnormal twisting or posture, you are ruling out CP, and then you are getting yourself into a. So Gaurav, what happens is very often the mother may give us that history, but we know eventually. So sorry, I'm just trying to be a little more from the examining, helping you from the examination point of view
Yes,
as well.
sir.
When you know that you are going to lead the matter up to saying that it is a CP, then even if that is, don't at least highlight that point, even if the mother may have said it. Or you could say that it is doubtful, but the mother says so. You have to see you are convincing the examiner. Remember that it's a difference between giving an exam as a student and practicing in the clinic like Dr. Suman and I do. So here your judge is uh, the examiner. So don't make any, even if the parent has told you something, camouflage that statement so it doesn't put you. At the end of the day, if the posture is normal, tone, and there is no twisting or dystonia, then why are you saying that there is a problem?
Yes.
So because you're presenting the case after doing the examination, isn't it?
Yes.
So if you feel there is a discrepancy between history and examination, try to, do things in a way that it is the examiner can understand those things well, and you do not get into trouble. ठीक है.
Yes, ma'am.
Hmm.
So activities of daily living, child can walk with support and child needs help in feeding, pressing, toilet, and functional status according to gross motor functional classification is level 4. Family history, there was no history of developmental delays, seizure, or any neurological illness in the family. The birth order was first and the product of non-consanguineous marriage, and there was no history of child loss or abortion. Socioeconomic history, a four-membered family with 2 rooms living in Pakka house, and the head of the family is father, with the education up to 12th standard and belonging to a upper middle socioeconomic status according to modified Kuppuswamy scale. Dietary history, child was exclusively breastfed until 6 months of age and then started on complementary feeds. And child only consume mashed food with vegetarian and diet. And time taken to complete the feed is 10 to 15 minutes. And based on 24-hour recall method, there was calorie deficit of 400 kilocalories and protein intake was adequate. And the required calories of 1400 with the required protein of 16 grams. This, this was a 24-hour dietary recall method. Immunization status, the child was immunized up to date as per national immunization schedule, and the card was not brought. Now, so to summarize, 5-year-old boy, product of non-consanguineous marriage with history of birth asphyxia, presented with complaints suggestive of global developmental delay, predominantly in motor, and seizures and tightness of limbs. The child has intact vision, intact hearing, no history of extrapyramidal movement disorder, and no fixed deformities or contraction. There was no significant family history, and the nutritional history revealed a calorie deficit of 400 kilocalories.
हिस्ट्री में कैसे पता लगता है? हाउ डू यू फाइंड आउट फिक्स्ड डिफॉर्मिटीज एंड कॉन्ट्रैक्चर्स ऑन हिस्ट्री?
अगर उनको बॉडी को कोई पार्ट मूव करने में बहुत ज्यादा स्टिफनेस हो और टाइटनेस हो रखा हो तो कॉन्ट्रैक्चर्स के लिए लेट साइन ऑफ सीपी.
नहीं नहीं, दैट्स ओके. नहीं नहीं, बट हाउ डू यू आस्क इन द हिस्ट्री?
मूवमेंट में ही अगर बहुत टाइटनिंग इतना ज्यादा है कि वो मूव ही नहीं कर पा रहे हैं उसको.
दैट विल इंडिकेट कॉन्ट्रैक्चर.
फिक्स डिफॉर्मिटी कुछ भी नहीं.
I think you have to say it only after examination that the contracture is there or a fixed deformity, that there is no movement after the pressure. But on history, you can just say whether there is a tone is increased or it is reduced, whatever.
Yes,
Can
ma'am.
I come in, Praveen? I've been listening to it. because-
Hanji sir. Good evening,
Good
sir.
evening.
You are
Good
there.
evening,
sir.
I'm not
Good evening,
Namaskar.
I
Sameer.
didn't see you.
Namaskar, sir.
Okay. Namaskar. कैसे हो समीर आप?
बढ़िया, sir. Thank you so much, sir. Thank
अच्छा, sorry,
Hanji sir.
Gaurav. Another thing which I wanted to point out,
Yes, sir.
when your history you are going about no history of this thing, no history of this thing, no history of this thing. Instead of that, just say no history of 1, 2, 3, 4, 5, 6. Why are you repeating no history of every time? You are wasting your time and the time of the examiner, and time is limited in the examination. ठीक है ना? So same on
Agreed.
that. Just say no history of 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. बस. You know, उसने फिर कुछ और elaborate कराना होगा तो करा लेगा. आप repetitive करो तो यूं लगता है कि I mean,
You're
if
not
today take the development तो आपको repetitive sounds बना रहे हो आप. So,
Or
repetitive activities
हाँ.
हमें टेंशन हो जाती है
So please
गौरव
don't do
आजकल
that. Don't do that. My saying
True.
this means that your presentation should be so slick and so good that the examiner should realize कि यार तुमने एक बारी नहीं 100 बारी ये procedure किया. Hundreds of times you have done it, and you have done it so well that there is no opportunity for the examiner to ask you a question also. It
True.
should be that rapid, that quick, and that smooth.
Yes.
Absolutely.
so some people, like sir is absolutely right. Is that sometimes the examination is an art of convincing the examiner more than
Yes,
anything else. That
absolutely.
is what sir is saying.
You have to lead the examiner that where the case should go.
हाँ बिल्कुल बिल्कुल.
Yeah. ठीक है. So don't use terms like this जो which you are not really sure of, और जो history का part है, history में examination का should not mix up both the things. Just take care of all these important points. And
Yes,
history में do not use, most of the time we use medical terminologies in history. Please make sure that you do not use, ये तुम्हें MBBS time से बता रहे हैं, do not use medical terminologies in history. Okay.
yes, ma'am.
ठीक. What about can you just elaborate on the feeding difficulty एक बारी? Just go back. The family history, nutritional history, there is no say. Was there feeding difficulty?
No. मतलब child has to be fed by mother only.
By
What
mother only.
what
Okay.
madam means is
There was no regurgitation or regurgitation
Child had
of
difficulty
feeds
in
or
chewing.
drooling of
yes,
saliva.
more than regurgitation, whether he had
Drooling.
difficulty in chewing. So remember we said even while breastfeeding was the child able to suck well. So after suck, then there is chew, then there is swallow. So all these things, this child would have had a problem of chewing. When you say he cannot feed himself, it could mean that he is not able to use his hands to feed himself. That's different from oromotor problems where he is not able to chew and suck and swallow. And the other thing is that you said there's a huge calorie deficit, but there's no protein deficit in a vegetarian fed child. So that would be a little bit of a
Yeah.
query, maybe.
Yeah, true. And if the feeding difficulties are there in a child whom you are suspecting cerebral palsy or neurodevelopmental disorder, you have to elaborate on that because it is an important comorbidity
Yes,
and
ma'am.
important this thing. So kindly elaborate on. Yeah.
I must say it in negative history about that. There was no regurgitation or drooling of feeds.
Chewing ठीक है? Chewing is fine.
Chewing was, मतलब he takes time, slow, it is slow, and we have to give mashed food to him for
So the
feeds.
other way the mother can interpret it is as a child is a picky eater. Picky मतलब यार यही चीजें खाता है, वो नहीं खाता है. So it tells you that he is not able to bite or chew. That's why he has to be given mashed food. So that is how you are developing your story that he has a muscular problem or oromotor problem as well. And in addition to the having problems in the rest of the body. That's, I think madam is asking. One more thing you could have asked mother whether she noticed any squinting at any time. Because that's one of the thing which you can pick up on history. And children may have a strabismus or esotropia. So that also mother would notice.
Yes.
Okay.
So after the history, differential diagnosis, perinatal asphyxia, and the points in favor are there's history of asphyxia, seizures, developmental delay, which is static, and there's increased toe. And for torch infection, there is a developmental delay, static, and seizure, but there's no history of fever or rash in antenatal history. For neurometabolic disorders, there is history of points in favor are developmental delay, there's static, there's seizures, increased tone, but there's no history of consanguinity, sibling death, or fluctuation of illness. And for structural malformations, the points against are The IQ and cognition is not that severely delayed.
Okay. I can. So, but in perinatal asphyxia, you said asphyxia and seizure, but seizure didn't happen at birth, isn't it?
Yes, ma'am. They
It
happened
happened. It happened later on.
6 months of age. Yes, ma'am.
So
And
we are not really sure whether it is HI or it is not HI, isn't it?
Yes, ma'am.
And the seizures happened only once, right? And even when you mentioned the history in the beginning that the child had seizures taken and then he was given Levipil and then the seizures stopped. So was it status epilepticus or did he have multiple seizures at different times and those seizures stopped after giving Levipil? So that part of the history could have been seen. Here again, when you say perinatal asphyxia in favor, significant perinatal history is what you should mention that, oh, he didn't cry at birth he he was not premature, of course, but whether there was prematurity, low birth weight, then that he was put on oxygen, he needed there was forceps delivery. So all this is you are building up the story to draw the examiner towards parental asphyxia. In
Yes.
torch infections, you are right. No fever rash, but also vision or hearing is very important when you are talking about torch. Then neurometabolic, there is a possibility of two things. One is that the child would have vomiting and failure to thrive would be far more significant and
Yes.
seizures would be, and again, there would be regression. Some amount of possibly would be seen. Structural malformations, you are right. IQ and cognition would be right.
ठीक है.
Okay. So general physical examination. On examination, child was conscious, alert, smiling, a playful, sitting in comfortable position with the reasonable interaction with surrounding and cooperative for examination. Vitals, the pulse rate was 90 with the regular good volume and no radio delay. Respiratory rate was 18 with saturation of 100% at room air. BP was 95/66 measured in right upper arm in sitting position. The capillary filling time was 2 seconds. There was mild pallor present. There was no cyanosis, clubbing, lymphadenopathy, edema, or icterus. On head to toe examination, the head size seems to be normal with anterior fontanelle closed. Eyes, ears, and nose were normal. There was no cataract or nystagmus or squint. The mouth was normal. There was no cleft lip palate. There was no signs of facial dysmorphism. Limbs were skin and genitalia spine was all overall in normal limits. There was no neurocutaneous markers. So anthropometry, the weight of the child was 15 kgs and length was 95 centimeter. And as per
Here,
the
Gaurav, here you should have mentioned. Did you mention contracture and deform?
yes, ma'am, in limbs there were no contractures.
अच्छा ठीक है. Okay.
Weight of child was 15 kgs and length was 95 centimeter. And the head circumference was 48 centimeter, which was 0 to -1 standard deviation. And the weight for age was 0 to -2 standard deviation. And length for age was -2 to -3 standard deviation. And the BMI was 0 to +1. So on development examination, gross motor, the child walks with support, which is attained at 12 months, and fine motor, there was radial grasp present, which is around at 9 months. Social and cognitive, the child knows full name and gender at around 3 years, and language, child can repeat 3 words, that is 3 years, and primitive reflexes were absent. So development quotient on examination was gross was 20, fine 15, language 60, and social and cognitive 60. Systemic examination. On neurological examination, the child was conscious, alert. There was speech dysarthria, cranial nerves, there was pupils were equal and reactive to light. Child follows object in all direction. There was no drooping, no squint, no deviation of jaw while chewing. Jaw jerk was brisk. There was no deviation of mouth while crying. Child moves head towards the sound. The gag reflex was present, and uvula was central in position with no trunk deviation of fasciculation. Motor system examination, according to modified Ashworth scale, tone in right upper limb was 2 and left was also 2, and right and left lower limb was 3.
So first specify the tone is increased and according to the then give the level.
Yes,
Directly don't go into the
yes, ma'am.
Ashworth score scale and all those things. What is the level? First you have to define that. Yes.
Yes. Power bilateral upper and lower limb was more more than 3/5. Reflexes, superficial reflexes were absent. The plantars were extensor, and the deep tendon reflexes were brisk.
Mm.
Gait toe walking was present. There was no abnormal movements. Sensory system was normal. The child withdraws to pain. There was no cerebellar or meningeal signs.
So how do you say, you said the child is not walking independently, isn't it?
Child
Then how
is
can you say
trying,
gait?
who can walk
Gait,
with support, ma'am, to
तो
hand
उसको
him
gait
walking.
बोलते हैं? Do we call it a gait?
Yeah.
है ना? So gait when child starts walking independently.
Yes, sir.
Okay.
So toe walking unilateral, bilateral.
Bilateral, sir.
Why? Why is it important?
So if their one-sided involvement is there only, so
Yeah, you mentioned that the
unilateral.
child understands gender. How did you know that? Go back in the slides. You had
Yes.
mentioned about gender. Yeah, knows full name and gender. What do you mean by that?
So he knows he's a boy or girl.
How do you know that? Did he say मैं लड़का हूँ? तुम कौन
Yes.
हो? And he said मैं लड़का हूँ.
लड़का मतलब I asked कि you boy or girl, तो he said कि हाँ. He knows about gender discrimination, about the gender senses. So
Because for you, for a child to be able to express about gender, his language has to be really brilliant, not just his social cognition, not just the cognition, but his language as well. So when you are saying that a child is able to express all this, then you are really saying that his social understanding and speech and language is very, very good. So just keep that in mind. Yeah. Go ahead.
on respiratory system examination, there was no significant finding. Cardiovascular S1, S2 was heard. There was no murmur. On per abdomen examination, there was no hepatosplenomegaly, and abdomen was soft and non-tender.
आराम से slow. हाँ.
Now summary: 5-year-old boy, product of non-consanguineous marriage with history of birth asphyxia, presented with complaints suggestive of global developmental delay and seizure and tightness of limbs with functional level of 4. And on examination, there was global developmental delay predominantly in motor region with stunting and spastic dysarthria and with hypertonia, spasticity of both upper and lower limbs with brisk DTRs, extensor plantars, and 3 plus power in upper and lower limbs with bilateral toe walking and normal cranial nerves and no organomegaly.
In summary, you are saying no organomegaly. What is the significance?
Ma'am, in metabolic disorders, there would be hepatosplenomegaly to, to rule out neurometabolic disorders.
But there is no regression or nothing like that. But there are no other, other symptoms
No, ma'am, there
also.
was no history of
So you didn't mention anything about other. If you are thinking on neurometabolic terms, then you would ask about other things also, no? Vomiting and other things which we have mentioned earlier.
Yes.
So any specific reason when you are summarizing? I'm not really sure why do we have to give. You are not suspecting, na? In your provisional diagnosis, you are not suspecting metabolic, isn't it?
Yes, ma'am.
So by giving organomegaly, I think we are trying to diverting the attention. And what about the speech? Speech के लिए you have said spastic dysarthria.
Yes, ma'am.
So but the language is well established.
Yes, ma'am, he can speak words. He can repeat words, 3 words if we ask them, but there's dysarthria is there.
So what is your now? What is your provisional diagnosis?
No, ma'am, provisional diagnosis of boy with a static encephalopathy, that is spastic quadriplegia with the global developmental delay with seizure, no cranial nerve or vision hearing defects with function level of 4, with no contracture or deformity, with probable etiology being perinatal asphyxia.
Oh, what about feeding? Feeding difficulties?
Mm. Yes, ma'am.
Is it an important comorbidity?
Yes, ma'am.
Hmm?
Yes,
Or
ma'am.
what about stunting? PM?
Stunting was there.
So if you go to the previous slide, no,
Yes,
nothing
ma'am.
wrong with it. To say global developmental delay with stunting with spastic dysarthria,
Yes,
but
ma'am.
are you telling us, or are you trying to tell the examiner that the global developmental delay is related most closely to stunting and stunting is most closely related? No, it's not. It is an indirect way. It's not. So when you say global developmental delay, I would like to hear predominantly motor and spastic dysarthria with hypertonia. The stunting can come later because then I'm trying to form an impression. Are you getting my point?
Yes, yes, sir.
Also, when you are saying global developmental delay and you want to say it's diplegia or paraplegia, or so all the when you say that, immediately we have to go on to when you say hypertonia, what is the distribution of hypertonia? Because by now you've done the examination as well. So if you see quadriplegia, hypertonia in all four limbs, so you need to mention bilateral or all four limbs, spasticity, whether it's and with bridge. So just make always keep saying about bilateral, unilateral. That's very important.
Yes.
Not only in that, in your diagnosis, you should also mention the level of lesion according to you. Where is exactly the lesion? You know, you will have to mention that also.
The white matter factor most likely.
यार वाइट मैटर तो सारी दुनिया में पड़ी हुई है. वाइट मैटर कहाँ पर, इन द ब्रेन,
Why?
कहाँ पर, किस रीजन
Cortical
पर?
region.
हाँ, तो वो सब आपने मेंशन करना है.
Yes.
Some examiner may just say, okay, tell me where is the level of lesion. Then
Exactly.
Yes, sir.
we'll- why? देखो ट्रैक्स अगर आपका चारों लिम्स इन्वॉल्व है तो कहाँ पर होगी लीजन. अगर दो, ये सब चीजें पता होनी चाहिए ना.
Yes, sir.
ठीक है.
है ना, प्रीमेच्योरिटी में कौन सा लीजन है, प्राइम
हाँ,
और उसमें कौन सा
बिल्कुल.
लीजन है,
HI में
एसिक्सिया में.
कौन सी होती है, यूजुअल लीजन कहाँ पर होती है, वो सब बताना पता होना चाहिए आपको. ठीक है.
Yes.
And what about this static encephalopathy at 5 years? Do we say static encephalopathy? When do we start labeling a child as a cerebral palsy or what is the
Mostly after 6 months, we have to diagnose
6 months
it.
kya? 6 months kya?
At 6 months, we have to, for early diagnosis and intervention, it is good if we diagnose at 6 months of age.
No, what you are presenting is that the child has static encephalopathy.
Yes,
So do
ma'am.
we call it a cerebral palsy or a static encephalopathy? At 5 years, can we label this child as a spastic quadriplegic cerebral palsy or not?
Yes, ma'am. We have to say spastic quadriplegic cerebral palsy.
So static encephalopathy is generally used the term is used when the child is young and we are not giving the label of cerebral palsy,
Okay, ma'am.
isn't it?
Yes.
But when the child is at 5 years and there is a significant tone impairment and you can see and you have all the history and examination of comorbidities as well, since spastic quadriplegic CP with global developmental delay with all the, and what about the head circumference?
Head circumference was between 0 to -1 standard deviation. There was no microcephaly noted.
Hmm. Okay. No visual and hearing impairment. Okay.
The next question they'll
What are the
ask you.
investigation?
Sorry.
हाँ.
Go ahead, Praveen. I'm sorry.
नहीं sir, please you ask.
The next question which they usually ask is it a primary or a secondary microcephaly? And how will you differentiate between the two? That
So,
also, okay.
yes.
So next important question is what are the investigations you would like to do in such child?
Mostly we are thinking about in after the case, it is a case of cerebral palsy only. But if we have to rule out other causes like metabolic causes, or so can do it's TMS, DCMS for the child, and if we can get an MRI also done to localize the lesion in the brain, and if they have a seizures, so we can get an EEG also done. And for vision and hearing impairment, we can get VP and BERA for the child.
Why VP Bera at this age? 5-year child who is speaking, who is
Earlier,
doing
yes,
everything. Why VP Bera? You can
but
do the
now,
clinical evaluation, isn't it?
yes, ma'am.
And hearing and vision evaluation has to be done for all the children with neurodevelopmental disorder. Okay, that's
Yes, ma'am.
mandatory. Plus MRI has been done in this child already.
Yes, ma'am.
So, and that will give you the clue that whether the have you seen the MRI?
No, ma'am. Reports.
Okay. So MRI will give you an idea that the child has a lesion or not. This will
Yes,
help you to give a final diagnosis, isn't it? So MRI is the important diagnostic tool in this child. You didn't tell anything about the seizure. What happened? One seizure happened once and levopill was started. Then what happened? Did it recur? What is the status? He's still on medication or not? Or what is the status?
when the medication was stopped by parents only, but
And
there was no recurrence of seizure till now.
दवाई
can
बंद
I
कर दी
request, can I request Samir to give his inputs because he has to leave. I know he requested me that I'd like to leave for some other meeting. So Samir, could you please put in your input so that then we can continue the further discussion?
Yeah, thank you, sir. Thank you. So I think you've done a very good job, Gaurav. So that's nice. Only just see, eventually we have to when we practice as exam for the exam. Now you've got an idea. So what happens is that we tend to just relate the history and the examination findings. What we need to also understand is where are we going to lead to. So now when you study for your exam after this case, what the major issue was the DDs you should study when you are reading it for the theory, you should also know how it will present in this case. So this back linking in your mind is very important. That will help you be a better, help you to be better at presenting the case in the exam. Unfortunately, as a student, we are only focusing on collecting the history, doing the jerks, examining and telling the examiner. But if you are, while studying, while you still have a couple of years to go, if you are able to relate, how will the history have changed in this child? How would the examination findings have changed in this child? If the lesion was at this level, what would have been the history, what would have been the examination? So think in a reverse manner while you are preparing for the exams. That's all I'd like to say. Otherwise, you have done a great job. Thank you.
Thank
Thank you, sir.
Thank you, Samir.
you,
I'll
sir.
take
Thank
it.
you very much,
Thank you.
Samir.
thank you, sir. Thank you, Dr. Sameer.
Praveen, anything further you want to add? You
I
please
think
go ahead.
हाँ नहीं बाकी तो do you have other things to discuss or it is only the diagnosis or management also you want to discuss?
No, slides and here
खत्म
only.
खत्म बस छुट्टी
ज्यादा
कर
टाइम नहीं है हमारे पास 5-6
हाँ
मिनट है
5
और
हाँ so we can take up the questions in the meantime isn't it?
हाँ
If there are
Q&A
any
ले लो
questions we can take the questions. I
Q&A
think there
में
are 4 questions.
या या
There are questions that any history of yellowish discoloration of eyes or exchange transfusion.
No,
Did you
no
ask?
history. Yes, ma'am. There
No
was no
history.
history.
You had all.
I've already mentioned it.
Yeah. So there was no history of any jaundice. Then there is another question that is history of neurometabolic diseases in the history. That we have already discussed. All those features you have to ask.
Yes.
Then did you check the anterior fontanelle at 5 years? Gaurav? Did you say so? I
Yes,
think I
ma'am.
missed it. So you should be careful. Don't make blunders, please.
Yes, ma'am.
Okay.
when does the anterior fontanelle close?
So about 18 months.
हाँ, तो फिर 5 साल पर कैसे होएगा?
ठीक है
नंबर 2
हाँ
Sorry, sir.
अगर होगा तो फिर माइक्रोकेफली कैसे होगी?
Yes, sir. Macro देगी फिर.
और क्या
Then
क्वेश्चंस हैं?
then there is a question of topographic and anatomic type of classification.
That's exactly what I was talking about when I said anatomic and this.
Hmm. Hmm.
Yes, sir.
So you should be familiar with all the chart which is given there कि कौन सी लीजन से कहाँ पे होती है, प्री मेच्योर है तो पेरीवेंट्रिकल लीजन है, ठीक है, पीवीएल हो रहा है, जब ये है तो थैलेमस, हाँ कहाँ कहाँ पे लीजन
Yes.
होता है, कब यूनिलेटरल है कब बायलेटरल है, दैट यू शुड बी वेरी वेल familiar with. And what is the difference between dystonia and what are the, like if the child has hypertonia, so how do you differentiate between spasticity and dystonia?
Dystonia is
Hmm.
what we see if there is a increase, matlab, twisting or involuntary contractions of the muscle, and the rigidity or spasticity is what we on examination what we find there is increased tone.
So spasticity and rigidity same है?
नहीं मैम, spasticity is because of pyramidal lesions in which mostly anti-gravity muscles are involved, and in rigidity it is extrapyramidal lesions, and both both groups of muscles are involved, and spasticity is velocity dependent and rigidity is not.
Yes. So in spasticity, you have a clasp knife type of acting,
Yes, ma'am.
isn't it?
Yes,
Velocity dependent. Whereas in rigidity, there is a lead pipe.
yes,
And dystonia is a movement disorder. Fine. Dystonia, do not get confused between dystonia and spasticity. Dystonia is a movement disorder. There is an abnormal contraction of the body. So that leads to dystonic posturing, which is a
Yes, ma'am.
persistent thing. Okay. So you should be able to differentiate, because most often we have seen children, students are not able to differentiate between dystonia, because your etiology and management will absolutely be different in both the times.
Yes,
So
ma'am.
please, if you have not seen, I request all the participants to please go to the clinic and see the difference between spasticity and dystonia and rigidity. Then only you'll be able to understand. I think we have done most of the things, sir, and it's already 9, I believe. So we can, नहीं 5 minutes है अभी. Any other question? There is one more question.
One more question.
और question है? When should centrally acting muscle relaxant be prescribed? अच्छा हाँ. Okay. So, do you want to discuss the management? What is the management of cerebral palsy, Gaurav?
Ma'am, it's mainly counseling and therapies, in which we have to give parental counseling and education, and after which we have to start child on physiotherapies and occupational therapies, and other therapies if there are comorbidities like speech therapy, or if there is other comorbidity.
नहीं 5 साल का हो गया बच्चा, फिजियोथेरेपी तो कर रहे हो, then what else?
We have to give therapies, मतलब for his daily improvement in daily activities, we have to give occupational therapies like
हो गया, occupational therapy हो गया. What else? Is there any medical?
we can use drugs for if there is increased spastic type of CP. Like
What are the drugs?
can use oral benzodiazepines like diazepam, or we can use baclofen, or we can use dantrolene, or if there is a focal spasticity, then we can use botulinum toxins. And
Yes.
in dystonia, if there is dystonia, then we can use trihexyphenidyl, or levodopa can also be tried for dystonia. And if there are
That's for dopa responsive only. That's for dopa responsive.
for
only.
dopa, yes ma'am.
Hmm.
If there is a chorioathetoid movements or extrapyramidal symptoms, then we can use tetrabenazine or rezarpine as a drug.
So it depends on, for spasticity, there can be focal spasticity or there can be a generalized spasticity. So for focal spasticity, botulinum toxin can be given. For generalized spasticity, oral medications can be given, which is like baclofen, the botulinum, baclofen and dantrolene. But for sometimes in severe cases, intrathecal baclofen can also be given, in which there can be a pump which is placed in the intrathecal space, and there'll be a steady release of the medication. Then comes the role of, for first 2 years. To simplify the management, I will tell you, for first 2 years, generally the early intervention and the occupational therapy is the treatment of choice. After 2 years, medication should be added. Medication depending on the type and severity of the spasticity. And then between 2 to 6 years, all the medication generally works well. And after 6 to 8 years, role of surgery is there.
Yes, ma'am.
If there is a lot of spasticity, then surgical interventions in the form of tenotomy and rhizotomy can be done, whether it is a local spasticity or if it is a generalized, then in that case, rhizotomies can be done. So this is how we have to plan the therapies, and along with that there are orthotics, or there can be splints which can be given to maintain the posture of the child.
Yes, ma'am.
Then any other question?
Yeah, Praveen, could you tell us what would you do to so that the patient can go or the child can go to school and education and all? How are we going to go about it now?
Yeah.
He's 5 years old, and we need to think about that also.
So, most important thing is, I would ask Gaurav also, what are the prognosticating factors? Like, how would you prognosticate the parents that whether this child will be able to walk? वो पूछेंगे ना, भी चलेगा कि नहीं चलेगा, हमें बताओ तो सही, आप treatment कर रहे हो, whether he'll be
Yes,
able to
ma'am.
walk or not. Then only we'll think of the schooling. So, just give us some points which indicate that the child will walk.
For good prognosis, we have ki if the child is able to sit without support by 2 years, then there are high chances that the child will walk unaided by 6 years. And if the child cannot sit without support at 2 years, but can roll at 2 years, then there are chances ki he can walk aided or unaided by 6 years. If the child cannot roll and cannot sit by 2 years, then that is a poor outcome for the child.
Okay, so in our child, at what age child started sitting?
Almost 18
2 years.
months and 20
Okay.
months he was started.
So we can always prognosticate the parent that there are high chances that child will start walking independently, as we are, giving the treatment with the medication and the therapies. But motor is one component. Along with that, we have to continue with the cognition and studies academics. So child has to be sent to the school. Especially there are different types of school these days. One is a normal school. There are special schools where a lot of the children who have a severe problem go to the special schools. There are integrated and inclusive schools are available, where within the normal school, there are different sections for these children, where these children can be given individualized attention and individualized educational plan. Educator is there to take care of 3-4 children at a time, so that they can pay more attention on the child, and their individual plan can be made on their occupational therapy, their education, and their speech therapy. Like the child has dysarthria also, the child needs a lot of support. So preferably integrated school is a good option for such children, and they should be enrolled. And there is a term called UDID. These days, these children have to get a UDID. There is a unique identity number which is given by the government. So every child who needs help from the government or needs admission in the school, they need this UDID number. So they go to the website, get this number, and go to the government hospital, get this number. And on the basis of this number, they can get admission in school. And so that these children can, as we can see in this child, the child has good intellectual and language capabilities. So it should be, so the areas which are less weak should also be taken care of. It is not that we have to just focus on the motor abilities. हम exercise ही कर रहे हैं, बाकी चीजें बच्चे की. So should be sent to the school with where help is available. And this child has to be followed up, and we hope that this child will be able to walk eventually with the treatment. और कुछ questions? Any other question? Anyone
Praveen,
wants
for
to?
my
हाँ जी,
sake,
sir.
tell me,
हाँ
is
जी.
Kulachi Hansraj still in action?
Yes, sir. But up to
Which
sir,
school?
majority, yeah. All that's more of a special school, in fact, sir. Nowadays, there are a lot of good schools which have come, and in fact, by law, this is mandatory that all the schools should have educator and counselor in their school. And any child who gets the admission in the school, they cannot remove the child from the school on the basis of disability. This is according to the PWD Act. They cannot remove any child. They have to provide the support to the school. But if the support is not there, it is difficult to handle those children. So integrated schools are available. A lot of schools are there. There's in Delhi, so they can get help in the schools. Anyone wants to ask any other question? Or otherwise, we'll wind up the today's session.
Yes,
Gaurav, it
I
was
think-
very well done. Very well presented. Well done, Gaurav. Hanji sir, you want to add something?
Just wanted to thank you and Sameer and Gaurav for doing a good session and wish you all a good night.
Good
Thank you,
night.
sir.
Good night.